So Julie, thanks for joining us this evening.
Thank you for inviting me.
Maybe start off by telling us a little bit about what NOVELL is.
NOVELL is a living laboratory concept. So it is a partnership between researchers, academics, designers, architects, stroke survivors, and policymakers, hopefully. The idea of a living lab is by bringing together all of these stakeholders, we can tackle an important question and try to innovate. So in our example, we're using stroke rehabilitation as the demonstration project for the living lab. So NOVELL stands for Neuroscience Optimised Virtual Living Lab. And the neuroscience is there because we actually know quite a lot about how people respond to the environment with their brains. We're designing a virtual environment and a virtual service that we hope will be much better than what we currently have.
So what does the neuroscience say about health environments, built environments, let's say?
Interesting, because I've worked in neuroscience for 20 years now, we're really at this cusp where we have the technologies to be able to see what is happening in your brain when you're exposed to different things. So we can think about neuroscience and architecture or neuroscience and the environment on a number of different levels. We're just doing a review now, which is of all of the literature we can find on the neuroscience and the built environment. So we'll be able to tell you more of that later. But you can also look at the fact that the environment itself changes how people respond. It also changes how the brain repairs itself after injury. Most of that knowledge comes actually from animals,
right,
as is a lot of neuroscience, because we can study their brains. And there's a whole field of work around environmental enrichment, where they put animals in denuded, unstimulating environments on their own, or they put them into what they call enriched environments and look at how their brains change and how they might respond to damage. For me, I'm interested in stroke, so there is actually a huge volume of research showing that if you really consider the environment and if you target physical, social, cognitive activity, so socialisation, cognitive activity, physical activity, that dramatically increases the rate at which an animal will have its brain repair after an injury and its the extent of its recovery as well. There is certainly a very strong scientific basis for enriched environments improving outcome. And we've seen this in aged care. We've seen it in the zoo. It's actually pretty fundamental knowledge that we have.
And you've experienced a number of health environments, and let's use that frame of denuded and enriched. Perhaps give us an example of what a health environment for you is denuded. We need not describe a particular hospital, but what sort of environments are they?
Environments that are unstimulating tend to be fixed, usually with very poor views or quality of view. The furniture within them might be fixed. And so if you picture a kind of environment which is supposedly a social or communal area that has chairs lined up along the wall with perhaps a high window but nothing else to look at. The colours are cream-coloured, hospital wall colour.
Beige.
That's sort of what you would call a denuded environment. The other is a single bedroom that is isolated, again with no view. I was recently in hospital with one of my loved ones. The experience of those kinds of environments is not a happy one and not cognitively stimulating, not socially stimulating, few opportunities for being active and engaged.
So then the flip, of course, is that enriched environment. So curious to understand from you what that enriched environment might look like, might feel like. How would you characterise it?
I think, again, if we flip it to opportunity, so for us in NOVELL, we're looking at, we talk a lot about access to positive and stimulating environments. If you were thinking of an environment that gave you choice, and not just choice, but actually really encouraged you to be active, to be physically active, socially active, cognitively active. So it's got interesting areas in it, or it's got spaces that make you want to explore. An environment as well that, of course, has the requirements for good light, nice views of outdoors, etc. A range of things that are thinking at that level of we as humans wanting to be stimulated.
It strikes me as something so basic, human interest in to have that amenity, to have that ability to see the daylight, to see the horizon, to not hear clutter.
Right.
Is it implicit? Are these things that we just all know and the research is bearing that out for us?
We have done a number of reviews around the elements of the physical environment that might impact on outcome after stroke. And what we see in the research literature in the health environment, and it is improving all the time, which is fabulous, is that we often have an effort that is just looking at one specific factor, whether it's daylight or noise or green view. Whereas we know, in fact, environments are more complicated than that, which is one of the reasons we really love our project, because we're trying to tackle that complexity. But I think you have environments where you are trying to unpack different elements. One of the projects that we did with one of my students, Michelle Shannon, was we created virtual environments and tried to unpack 16 different factors by putting someone who had had a stroke into the VR system and exposing them to all of these different environments that were exactly the same except for one thing. That's actually trying to tease out the single factor. We hadn't tried this before. Did it work? It did work. It showed us that there are certain things, like you've just said, access, vision of the green space is preferred over looking at a wall. We have actually known that for quite some time. We also looked at spaciousness and noise and single versus multi-bed rooms, which is a big issue for us in our project.
And Julie, I mean, I know we talk a lot about stroke rehab, but I think of the amount of projects here in Victoria. They're across acute health, subacute health, public sector residential aged care, and you've referenced that briefly.
Yes.
Is what you're talking about applicable across all these projects?
We think so. We think that what we're doing is trying to create a method of interrogating what is most important for that particular type of service. But some of the things that we're finding that are important to our users, our stakeholders, and that includes stroke survivors, staff, policymakers, designers, it will be the same across other areas of health. However, a rehabilitation recovery environment would not be the same as an emergency department. They will have their own elements that are really critical to understand the user's needs.
So let's maybe drill into that a little bit and talk about this idea of good design. And we hear a lot about biophilia, salutogenics, all these other buzzwords, let's call them, whereas you're caught in the research, the neuroscience. So in your mind, what does constitute good design?
Two things I'll pick up on just for that question. One is biophilia is a theoretical construct. You know, it's an explanation of why that kind of approach might work. One of the things we have done is look at all of the different theories that underpin design. There's at least 12, if not more. So I think what's really interesting and important, in fact, is identifying what theory you're adopting as part of your design, and then making sure you carry it all the way through, which includes not just the theory behind why you're designing, but then how are you measuring to support that design. And then really at the end, looking at whether or not you achieved what it was that you were
set out to do.
Right. To me, good design is meeting the needs of your users. So that's your particular patient group. It's your staff, and staff are critical, especially now in health, because it's a very high stress environment. We're trying to keep our staff. But it's also, good design is thinking about the future of the building, not just how it is now. So is it going to be flexible? Is it going to be sustainable? Does it meet good environmental credentials? Because I think we have to get to that too. So good design is really meeting our needs of our users, our staff, our patients, our user group, having that future thinking for the flexibility of it so it can adapt to new uses as the health service changes. Now we have a huge interest, as we should, in virtual care and virtual rehabilitation and rehabilitation closer to home and new models. And we should do that. It's very old-fashioned to have people coming into hospital to have care, and we actually don't want them in hospital.
So good design starts even before we talk about a building.
Yeah, absolutely.
And how much of that is happening in the NOVELL as well, so that good design is something to do about the way care is delivered.
Absolutely.
And that it may actually result in digital tools or wearable devices.
Right.
Yeah, talk to us a little bit about that.
We didn't want, and this is the beauty of the multi-stakeholder living lab, we did not want to only create a new design for a building, because a building is there for a purpose, which is why I say good design is about meeting the needs of your users and, of course, meeting the economic needs of sustainability into the future. So we didn't want to just do the building, we wanted to do the service as well. Because in my view, a redesign, whether it's a remodel or a rebuild, is an opportunity for innovation. That's your opportunity.
A big change.
Golden.
Yeah, yep.
So don't just do what we've done before. Think about the whole thing. Think about the service model. Think about how the service model is supported by the environment. They actually have to be brought together. One of the things we did early on in NOVELL was we wanted to look at how the design guidelines for the building talk to the clinical practice guidelines for the service.
Yep.
In our example, in rehabilitation. So we pulled up the Australian clinical practice guidelines for rehabilitation, and we pulled up the Australian guidelines for the built environment for subacute care. And we tried to see how they really supported each other. And the answer was that there wasn't even a common language for us to be able to make sure that best practice care and best suggestions and practice for guidelines were linked. And that was the start of us going, well, we have to create a way that we can build the service innovation and the building at the same time.
It strikes me, I think of some of the built examples over the past 10, maybe even 15 years here in Victoria. We've been fortunate. We've had buildings like the Royal Children's, the Comprehensive Cancer Centre, even Bendigo Health. They all tend to be very large buildings. To put you on the spot a bit, do they reflect, do you think, good design in the way you've described it?
A whole building is a very big beast. What I would say is that I would love to have seen evaluation of those buildings by the users of those buildings. I would also love to see awards for a building's ability to meet the needs of its users, not just for it being beautiful. I think what we see is that there are elements of all of those examples that probably work incredibly well. But I also hear that there are elements that don't. So they haven't met the needs. And why is that? Well, we are told that it is a case sometimes of not having the time to do the consultation, not having the time to really be able to think about innovating a service model, which is what you would like to see, at the same time as innovating the building. It's a feature of how we currently commission, perhaps, that just means that lead-up time, it might be inadequate to try and really nail everything.
And if we did nail everything, assuming that we've nailed parts of it in some of these buildings, what difference does good design make for the consumer? Why is it so important?
Of the research that is out there now, there's really clear examples that good design can change a number of things, not just for the users, but for the whole kind of way our health system functions. If you get a good design that allows a person who's had a trauma to come into hospital and have efficient care and feel safe and know what's going on, so they're in control, they will get out of hospital more quickly, they'll have a positive experience, and those benefits will flow on into the future for them. If we have someone in our new facility, our goal is to try and help them transition more quickly home, but it's not just about length of stay. Move into a new model of care, which might have much stronger virtual element. So that faster transition. Be more able to be autonomous and practice more, not be tied to the bed. There are lots of things that I think a good design will do that can help people recover more quickly, help their families feel supported, get staff to be able to deliver their care more efficiently as well. The hospital building is not just a thing. It is there to actually support best care. That's its job, right? And so to me, if you get that right, you're going to elevate so many different elements of someone's outcome.
What strikes me in what you're saying, Julie, is we all know a building can't cure cancer, of course, but it can help the people who are striving very hard to cure cancer to help other people get as well as they can. That says much about the staff as it does for the patient. So tell us, what does it mean for staff?
I think we can look at poor design for staff and go, well, that doesn't work. Making it harder for staff to do their job, making it more demanding for them to operate within that environment, whether it's because they can't see a person that they're worried about, or whether it's because they have to walk really long distances to get anything that they need.
They get lost in traffic.
All of that contributes. So if you can create an environment that works well for staff and for the patients will also feel supported, they'll feel safe, they'll feel able to do things for themselves, and all of that helps. There was a great story actually from the children's redevelopment, and there was some nice research that was done there around wayfinding and legibility of the building. They looked at what the staff had to deal with every day in terms of people getting lost throughout the facility. And that was before they did the redesign. And the statistics are huge. It's an average staff member getting interrupted or being asked 5 times a day by someone, whether it's a family member or a patient, how do they get around, where can they find X, Y, and Z. That's every single staff member. So if you get that redesign part right, all of a sudden that's gone because people know their way around.
So it's interesting. It's rather than costing more money, as it's often framed, good design costs money, it actually saves money in terms of the efficient delivery of care. Is that a conclusion we can start to make?
I think we need to frame cost differently to what we do now. And it's one of the things we're building up in NOVELL, which is how do we think about the built environment as adding value to healthcare?
Yep.
And not also just think about it in terms of its first capital cost, but think about it in its longer term benefit and what's needed to sustain it. But also, if you get the design right, it should be flexible into the future. And that will actually save you money, be more sustainable. I think just extending the way we think about cost to think about value, not just cost.
And I think that value can be a co-designed metric too, can't it? It can be the outcomes that consumers value or the outcomes that staff value.
Very much so. In fact, I think that's vital. I think we have to get away from just thinking about length of stay as the only metric that's important in healthcare. We have to think about what can you gain from delivering excellent healthcare to the patient, to the staff member, and to the system. It's much more than just length of stay or preventing falls, for example.
So, Julie, I'm curious now. We've talked a lot about past examples, the RCH, and my mind goes to being able to manage your own environment. And I think of the leaps and bounds that Victoria have made in mental health spaces post the Royal Commission, where consumers can manage closing their own door, dealing with what they see through the window. But I'm curious to understand, as we go on, there seems to be an ever-increasing reliance on new technologies, new gadgets that people can use. What does the future of good design look like? Is it more technology, or are we at a precipice of trying something different?
Technology has a really important role in the future. Certainly in our example of this demonstration project for rehabilitation, a huge challenge we have now is that people feel that they have to stay by their bed because they've got to wait for the doctor, or they have to wait until someone tells them when their appointment is, or they don't know where they're allowed to go, or they don't track their progress, or there's a lot of things that are actually fundamentally wrong with that approach. Technology can help free us up, can help the patients be freed up, can help the staff be freed up. So as an example, if we were able to flip it so that it truly was patient-centred care, which we talk about all the time, but rarely deliver, if we're truly going to flip that, then what we will end up with is a doctor going, oh, I'm doing my rounds now. Where is Mrs. Smith? She's in the garden. Great, I'll go and see her there. Not Mrs. Smith has to stay by the bedside because the doctor is going to be coming round on the ward round. Or she would like to go and do her therapy. Is the room available? Yes, it is. Great. Can I book a slot and I'll go down there now? This might sound like a pipe dream, but in fact, I think it is coming, let alone our move to having maybe hybrid treatment where you've got some patients who are in person and some patients who are at home, linking in to join in a group. This is happening now. It's quite real.
That's what struck me. A lot of what you're describing is available now.
Right. What we have to make sure we do is we have to make sure that the technology that we have is built for purpose, fit for purpose, about our users, about our staff and about our patients. Just make sure that we don't just jump on the next good thing, but actually really make sure it works and it's simple to use.
So the good design in the future might be
good design of technology too. Absolutely.
And you talked about consumers being able to manage their environment. You also talked a little bit about them being able to comprehend their environment, presumably help legibility. Tell us a little bit about meaningfulness in their built environment.
Well, that's a great question.
Okay.
It's really important. One of the things that has always struck me as a therapist is that when I have a patient come into a new environment and I might say, hello, my name's Julie. I'm here to support you on your recovery from your whatever. Today's our first day, so let's get to know each other. Would you like to go somewhere in the building? And they'll say, I don't know, am I allowed to go somewhere? Or where do you want me to go? So either of those answers is I have no control over my space. I'm sitting in my bedside chair, which I know I have control over. The second part of that answer is you are going to tell me what I'm allowed to do.
So there's an imbalance in the control there.
A lot of my earlier research before I started getting into built environment was around people's activity within hospitals. And I can tell you that most people will spend 80% of their day in a hospital, in or beside their bed. Now, if I then flip that into a recovery concept, even in mental health, wouldn't we want people to feel that there were spaces that were safe for them, that gave them choice and variety, that gave them opportunity to express themselves differently, feel differently, and they would actually then go to those places.
So I'm curious about meaningfulness then in having those dimensions, because I think there's a cultural dimension to it as well.
Right.
How have you embedded First Nations people in some of the research that you've done in terms of co-design and what they value? Or I know we often think about, as I did growing up, people who not from an English background trying to navigate a complex environment like a hospital. How does some of those avatars or, that difference and what they might hold as meaningful come into some of the work that you do?
I think if you're designing specifically for people, First Nations people, it's absolutely critical that you have them at the table and are working with them from time dot. And I know that that does happen. So when there are specific facilities for Aboriginal and Torres Strait Islander people, there are some great examples in Australia where they've done that really well. But we have people who are very diverse coming into our hospitals, and it is a challenge, actually, to find the stakeholders, the consumers, to bring them in and have them as part of your co-researcher team. That's what we've called them.
Mm-hmm.
So anyone that's involved in our project, whether they're a policymaker or a stroke survivor or an architect, anyone that comes to contribute becomes a co-researcher in our project, which I think is important. We try to give them that sort of power in the relationship. Co-design is not simple. Even co-design for vulnerable populations like people with mental health disorders or who've had traumatic experiences, what often happens is that the designers rely on the thoughts and experience of the staff to be the voice of those consumers.
Sometimes things get lost in translation, I think.
I don't think that we always know. So I would say I've had 30 years of experience in working with people with traumatic brain injury, and when we started this project and really brought in a large number of stakeholders from as consumers, stroke consumers, consultants, or researchers, it was really there were things in there that I'd never heard.
Yeah.
And I'd worked in this field for a long time, and they're going, oh gosh, no, this is what I want, and this is what was missing. There are ways that we can effectively co-design. You can't co-design with a cast of thousands. Mm-hmm. That is a challenge. I think you have to, though, really put it in as a priority for good design and make sure you do it.
So it sounds like, if I were to summarise, good design is as much about the design of the service, but then it's designing the design process to actually get to good design.
I agree. And I think that that's what we're aiming for, models and service models that will come out of this project, because we will then evaluate an array of them to come up with a final idea. But what we've really done is create a methodology. So we've created a method of working through these complex processes and trying to find ways to interrogate them with rigour and do it in a way that is inclusive and do it in a way that has this co-design potential, or a core actually, so that we know that at the end of this it will be representative.
You've used the word interrogation, evaluation. I'm guessing you're not sensing that there's much of that going on in our health-built environments at the moment. Tell me a little bit about, do we do enough post-occupancy evaluations? Do we go away and actually ask people? I mean, this is the claim made by the design team about this particular environment, but how is that resonating for you?
It's not very much.
It's not very much done.
It's not very much done, and yet to me it's critical.
Mm-hmm.
If we have a brief and functional briefs that really get to the core of what you're trying to change, then it seems absolutely imperative to me that you have to check and know whether you met that brief. But the other thing that I think is really important in improving health systems, like we do in improving health care. So I'm also a clinical trialist, so I do randomised controlled trials, the highest level of evidence, and I have to report whether they work or not into the public domain. Post-occupancy should be an evaluation of, did you meet your ambitious, hopefully, targets for this building and for this service? And they, I believe, should be made public and be transparent, and people should be actually applauded for doing that. So not criticised for it, actually applauded for that. Because how can health systems learn and how can we improve if we don't know whether things work? So I think what's missing is actually a standard approach to how we do this, and then the willingness to actually put some money into the projects. If you have a huge hospital project, there might be some parts of it that we know already from previous research and evidence that are going to work quite well. And maybe they're not your target.
Mm-hmm.
But if you've really made a big effort to try and radically change the emergency department, or how ICU functions, or the waiting room at pharmacy, or whatever, then I think you can work at it at a modular level. You can go, right, let's look at that because we really wanted to solve that problem.
Do you see any client around the world who does that well?
In Sweden, it is a policy that they are required to have this sort of learning that comes at the end of a publicly contributed to, if not fully funded, building. It's public money. I think it's quite reasonable to have that as an approach where there's a standard that they apply. There needs to be a way that we can have an evaluation that is also done in a rigorous way. I know in Queensland they've thought about that, and I think have done a bit of work to try and create a standard, but we have nothing across the whole of the country.
I think we're about to change that with the Australasian Health Infrastructure Alliance, where we've agreed to actually develop a national standard for post-occupancy evaluations. And it does seem to me that if we can have an agreed way of measuring the outcomes of buildings, then we've probably got a much better way of determining what constitutes good design, because we can point to, here's what the evidence says, and if you do those 5 or 6 things, you're more than likely on the pathway to good design.
Absolutely.
There's an obligation, I would have thought, to think about good design because it has a greater longevity.
Oh, completely agree with that.
So, Julie, what's interesting, ultimately, there'll be a young architect who'll get stuck in a lift with a very important client, and they'll be asked, what are the 3 things you need to know to design a fantastic health environment going forward?
You've got to understand your users, which includes patients and staff. You've got to know the evidence because I think we've got to use that too in all of our design. So what does the research tell us? And then also do something quite beautiful and stimulating, because good design is a combination of all that: functionality, evidence, and something gorgeous.
Wonderful. I love aesthetics. Thank you.